So today I will discuss negative antigenuria in a dog with suspected CNS localized blastomycosis. This is out of JAHA from 2023. It is not open source, so I'll just go through the abstract and give you my takeaways and learning points from the article. So this paper is about a 7-year-old female spayed mixed breed dog that presented for a 1-week history of neck pain and pelvic limb weakness. Exam revealed non-ambulatory paraparesis and thoracolumbar hyperesthesia localized as a T3L3 myelopathy. MRI revealed extensive intramedullary T2 weighted and stir hyperintensities and diffuse severe T1 post-contrast meningeal enhancement of the thoracolumbar spinal cord. A lumbar tap was performed and cerebrospinal fluid revealed a suppurative pleocytosis with a total protein of 4,300 milligrams per deciliter and a white blood cell count of a remarkable 352,000, 81% mildly degenerated neutrophils. Various infectious testing was submitted, including agar gel immunodiffusion for fungal diseases. While awaiting the results of infectious disease testing, the dog was treated for suspected meningoencephalitis of unknown etiology and was given corticosteroids, cyclosporine, and cytarabine arabinoside. The dog neurologically declined and was started on broad-spectrum antibiotics. The dog continued to decline despite antibiotics, and infectious disease titers subsequently revealed serum antibody positivity for blastomycosis. The dog was then referred to a multi-specialty referral hospital and was treated with amphotericin B. Before starting amphotericin B, a GGT to creatinine ratio was performed for baseline renal function. For those not familiar with amphotericin B, it's generally given every other day or a Monday, Wednesday, Friday schedule for a total of no more than 10 dosages. Renal function should be evaluated during treatment and stopped if damage appears significant. In this dog, the GGT to creatinine ratio did increase to about 1.8 times baseline, but that's not very significant, so treatment was continued for the total of 10 dosages. Itraconazole was discontinued during treatment with amphotericin B because of liver changes noted on the blood work. Following amphotericin B treatment, fluconazole was given for an unspecified amount of time, but for at least 5 months. Prior to treatment, urine blastomycosis antigen testing was submitted for subsequent disease monitoring but was negative. 5 months after presentation, the dog was clinically doing well with no identifiable neurological deficits. This case demonstrates that neurologic blastomycosis may have negative urine antigen concentration in some dogs and that other diagnostic modalities should be pursued when central nervous system fungal disease is suspected. Other takeaways are that if you do immunosuppress a patient with blastomycosis, you can still treat with antifungals and the animal could have a good prognosis. I will comment that if you have degenerate neutrophils, especially given that high of a cell count, MUE would not be my first differential. SRMA potentially, but that would still be unusual to have SRMA with degenerate neutrophils, although on occasion we see it. And it does stress the importance of having a good cytologic evaluation. Something I learned from this paper is that Michigan's lower peninsula prevalence of blasto in dogs is less than 1 case per 100,000 versus those that are within the northern aspect of Michigan, the prevalence is as high as 200 cases per 100,000, at least looking at just the dog population. It is surprising that the urine antigen was normal, but no test is perfect. I don't have an explanation for this other than, again, no test is perfect. One could argue that the AGID was a false positive, but given the response to treatment, I feel this is unlikely, especially as other fungal testing was negative, and I feel like the cross-reactivity because of this is unlikely for the AGID. The sensitivity for the urine antigen is 93 to 95%, and specificity 95 to 100%, although given the cross-reactivity for histoplasmosis, the specificity is likely a bit too high. These percentages are not looking at CNS-only blastomycosis, so maybe the location of the infection is related to the antigen being normal versus the agar gel being positive. So overall, that's a fairly straightforward article and does a nice job highlighting the elusive nature of some of the fungal infections. But that's all I have. Thank you.